people and pay respect to their spiritual relationship with their country. I'd also like to acknowledge the traditional custodians of the various lands on which you're all joining us from today, and any Aboriginal and Torres Strait Islander people participating as well. I pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal peoples, their ongoing cultures and their connections to lands and waters. So what are patient-reported measures? So PRMs, as the acronym is, are surveys that help us to understand what matters to patients in the shortest way of defining it. They help us to find out if the care that we're delivering supports the outcomes and experiences that patients expect. PRMs can be broken down into two different areas. So patient-reported experience measures, or PREMs, and these are perhaps the surveys that you may already be familiar with, depending on your backgrounds. These are where we are often in a single survey after a healthcare visit, for example, seeking to understand a patient's experience with the health service. The data is separate to the medical record and is often, almost always, de-identified. Patient-reported outcome measures, or PROMs, are there to assess quality of life and symptoms and functioning, and are usually repeated over time. And then the data is held and is part, I guess, that patient's interaction with their healthcare provider. We'll go into that in a bit more detail, but just at a really high level, usually held as part of the medical record. So we're not going to go into this in detail, but really just to suggest that when we're talking about PROMs, patient-reported outcome measures can sit in a variety of different areas. And so this picture really just describes the depth and the breadth, so that patient-reported outcome measure surveys might be domain-specific, disease-specific, or they can be quite generic. I'm not going to go into that in any more detail here, but certainly good to understand the way that can be broken down across patient-reported measures. Patient-reported measures are of a benefit to us providing patient-centred care across our systems. And so what we know is that value-based healthcare, where we're measuring health outcomes against the cost of delivery, does equal better care, that we need to understand staff experience, that we need to understand patient experience, and that we need to build into that the patient-reported outcomes from their own perspective to help tailor the healthcare systems to their needs. Clinical outcomes are really important in driving that, and then efficiency data, so data driving the decision-making for improved efficiency of better patient care. Importantly, though, that is all centred around the patient-centred care. So when we think about patient-reported measures as a data set or as a measurement that we can introduce to the system, we think about it in some different ways. So if we think about where patient-reported measures can be used to support value-based healthcare, we're able to provide patients with an opportunity to voice values and concerns. We're able to quantify patient outcomes and experience, empower patients in shared decision making, which is a really core part of where these measures are useful, and we're able to develop and review services out of that, contribute to audit and to research. So I guess what we're describing here is where making the measurement is really critical, and certainly at the centre of our program, which I'll talk a little bit more about later on. Really at the centre of our program is about using patient-reported measures in the patient and clinician engagement and at the core of shared decision-making as a way of determining the patient's reported experience and the patient-reported outcome as core to their decisions about their care. And then at the service level, being able to contribute that insight to quality improvement and to changing practice and making things better. And then at the system level, so being able to use that data to inform population level evaluation, so big picture system service redesign and service planning longer term. And absolutely at all of those levels to be able to add insight and drive new evidence in both practice and in research and research translation. So the focus is often on selection and collection. And obviously, there's a careful planning required when we look at that use. So at the micro level, as I've already described, in that clinician and consumer care decision-making element, the meso level, the quality improvement and a sort of more formative function, and then at the macro level for performance assessment. In other countries, there is absolutely work around patient-reported measures in the space of being about paying for performance and more public provider, more public reporting around performance, and also the opportunity to use that sort of in the context of preferred providers, and depending on how these measurements are applied. Just an overview briefly then of patient-reported measures across the landscape. So at the moment in South Australia, the team at the CEIH have conducted a reasonably, over the last couple of years, a reasonably significant environmental scan to really understand how patient-reported measures are being used. Absolutely, we see patient-reported outcome measures used in clinical practice, and we see it used for research, for research and in health economics. We know that surveys in such as the RPEX, which is the survey that's done around patient experience in South Australia routinely, is done as part of the South Australian Department of Health's contract. So the Department of Health and Wellbeing have a contract, and that is delivered to patients as they are discharged from inpatient stays, or select patients as they're discharged from inpatient stays. We know that there's individual collections happening across local health networks, primarily in a paper-based format, through clinicians. Some local health networks have PREMs programs, so patient-reported experience measure programs across the board. And we know that there are collections of those in places like SA Health's Quip Hub, for those of you that work within SA Health. There are individual and service-led initiatives, and then for us, there is the current implementation of the statewide patient-reported measures program. I'll go into that in a bit more detail later in the conversation. Then we present for you a bit of an overview of what's happening interstate. Certainly one of our key partners in our work has been the Agency for Clinical Innovation in New South Wales. They started on a journey for implementation back in 2015 from memory, and they are going through a process of implementing a digital solution currently. We also see Queensland, Victoria on slightly different, but on their journeys for implementation. At a national level, the Australian Commission on Safety and Quality absolutely values patient-reported outcome measures and patient-reported experience measures, and there's a lot of work there. If you Google it, you'll find it really easily. A lot of work there, which is starting to make these measures matter. Because they're being measured and because they're being valued in these really important data and reporting sets in particular. I won't go through in detail the rest of these, but you can see there are other examples at a national level, actually, just to mention the YES and the KES, so across mental health patient experience measures being reported in a reasonably, a very standardised universal sort of way across the nation as well. Internationally, there are some big movements, one being ICHOMS, which is enormous, and that is a consortium for health outcome measures. There is the PARIS, so the development of a tool through the OECD happening at an international level, and other various programs. Again, there are a collection of PREMs happening through individual service-led initiatives and across organisations, and importantly for really different motives, so for really different reasons. And what we see internationally is that in countries that have different funding systems to what we're quite lucky to have here in Australia, it is being driven by by insurers, by funders. So the need to do this is being driven so that they can measure what is being delivered and then make decisions about what they pay for, which is really different to the approach that we're taking here. And I'll talk a little bit more about that as well. Just briefly wanted to touch on the Commission on Excellence and Innovation in Health. Our vision is together, let's create better healthcare for all South Australians. And so for us, in developing that vision back in 2020, I think it was, so at least 3 years ago, we knew that we wanted to be able to measure better. And we wanted to be able to say that if what we're doing today changes, if we're a commission on excellence and innovation in health, we weren't prepared to say together, let's create excellent healthcare for all South Australians, because how would we know we were excellent? What would that measure be? And so when we said better, we knew that we wanted to then start to measure what better was. Down the track shortly after that, we landed in a position where we wanted to be able to make measurement of patient-reported outcomes and experiences matter, and we're lucky enough to recognise the opportunity to lead work for South Australia to make this matter. We believe that our vision for healthcare in South Australia is that everyone has access. So it's about that equitable access. So I'm really lucky with the bio that was read out about me before the video started. I think equitable access to care is what makes me tick, and so that's certainly central to the work that we do at the CEIH. But that everyone has access to provide that care to the latest evidence and data to make the best decisions is the next layer down to that. We think it's really important that innovation is encouraged and it's safe to think big and try new things, and that absolutely nothing is done in isolation. It is about collaboration and partnership, hence our partnership with Health Translation SA, and also with Nadia's team when I hand over to Nadia shortly. So out of that, we were able to identify that what we wanted for the health system in South Australia was better healthcare outcomes and better experiences for everyone, for patients and staff and all of the humans, I guess, involved in the process. We needed to start to make the measurement of those things matter. So there's a saying that goes, what you measure matters. And so if you start to measure things, they start to matter. And we start to build those elements in. And so what we decided was to bring together a program, and we went to the then CEO of the Department of Health eventually with a business case that says, actually, what we would like to see is patient-reported measures matter and be present consistently across the South Australian healthcare landscape. To get to the vision that is displayed on the screen currently, which I'll go through in a bit more detail, but to get to that point, we did a lot of consultation and a lot of work understanding both from a consumer and a clinician point of view and from a healthcare administrator point of view as well, what people wanted and what people already understood about patient-reported outcome measures and what we found, outcome and experience measures. And what we found is that there are some really fantastic pockets of excellence already in our system. And when we talk to people about the barriers to using patient-reported measures in their work, one of those barriers was the lack of an IT system, the lack of a digital platform. And so the CEIH's program in South Australia is about making patient-reported measures, making the change in practice to using patient-reported measures, making them matter, and subsequently implementing an IT system to enable that. So recognising that for many people who understood that, not having an IT platform to do it was a barrier. So our program is absolutely at its core about the change, about creating the change in practice. The vision that the group that initially led the consultation and was involved in the consultation agreed on is a health system that recognises a health system that recognises patient-reported outcomes and experiences as vital, where feedback is available in real time for clinical and consumer decision-making, and information is used at the health service and systems levels to drive excellence and innovation. So hopefully you can see how that vision statement is kind of the cumulation of the story I've told up until this point. The principles that have been built into that program are excellent user experience. So we want to know that users, so certainly consumers and clinicians, have an excellent experience of that. We heard really clearly from the consultation that safety was really important, that transparency was really important, that we needed to be inclusive and equitable in the approaches. Clearly, the consumer and clinical partnerships were really important, and that's why it's such a good fit that the CEIH, the Commission on Excellence and Innovation in Health, is leading this work, given our existing remit in that patch. The other thing we heard loud and clear is that we might not get this perfect, but don't wait. And so that's been a really important principle for us to hold on to as well, that we need to go and we need to achieve this vision. So initiating the statewide program, as I said, we've done lots of work to map the current state and understand who's already doing excellent work in these areas. We have held many stakeholder workshops and developed those visions and principles and identified the barriers. And as I say, that business case went through to the CEO of Health some years ago, and they were really supportive of us planning and developing and seeking, getting the indicative pricing, working through the approvals to be able to implement an IT system, but remembering at all times that this is actually about the change in practice that we want to achieve. And my team hear that once a week, if not more. We have a fantastic team of implementation managers who have a perfect skill set to be able to do this work and the implementation working in the change. So yes, you can implement an IT system, but you still need to change practice. The program commenced formally, I'm going to say 2020, I'm going to get that wrong, 2021. July, but we then moved through the process of developing technical solution requirements, procurement planning, all of those things. So we did, through that process, consumer engagement being obviously pivotal, but given this is about patient-reported outcomes and experiences at each of the phases through across the last 3.5 years, and into the future we have some plans for where we're going to take that and the exciting opportunities for us to build in some consumer leadership and advisory into those elements as well. And we have had, through our research collaborative partnership with Health Translation SA, the opportunity to offer a consumer-led grant as well. So we'll perhaps hear more about that. So the PRM program timeline, so as I said, July 2021, the program board convened for the first time. We've been through the joys of procurement, through government procurement, and we have procured a digital platform that is specifically purpose-built for patient-reported measures. We are just working through our stage 1 implementation, just finalising, dotting a few I's and crossing a few T's in terms of our implementation scope for stage 1, and stage 1 will be early in the new financial year, so July, August. There won't be a big bang go live date, so I don't have to give you a date and then pull it back later on, but it will be in the next couple of months. And then we'll start to do our planning as we learn from that implementation. We'll start to do our plan for the next stage. The implementation approach will be both looking at PREMs and PROMs. And so the nature of that will mean that we will have some things that will go live across all services. So there'll be patient-reported experience measures perhaps that go live across all different health services, but for one measure. And then there will be, in that first stage implementation, some specific groups. So I showed earlier that a patient-reported outcome measure might be for a specific disease group, for example. And so we will be working in some specific areas and then some more general areas for experience measures. We'll initially be aiming to work with services who already have the practice, so who already have already adopted patient-reported measures as part of their practice, but the new part would be a digital platform. And then over time, we'll start to look to onboard services who will also be adopting patient-reported measures into their practice, as well as a digital platform to do them on. So it's sort of a staged approach in that sense. And I've already mentioned the implementation managers, so a fantastic team who will make this all happen. Important enablers for us have been the existing local PROM success stories, and there's some fantastic teams who are doing great work across our system already, using patient-reported outcome measures to really share decision-making with the patients that they work with every day. We are fortunate to have unique health identifiers in South Australia, so we do have a really great opportunity with our system infrastructure and permissions, and obviously the EMR implementation being statewide and in the latter stages of implementation. You may be aware that all of Metro is now live with EMR and won't hopefully be long, and we'll have country on board with the EMR as well across the public system, and so that'll be fantastic. I think the other enabler has been the clinical tolerance for digital change. That can still be a barrier on some days, but certainly people are open and ready to change. We've seen the implementation partners, so the ability of the CEIH to maintain focus on this over the last couple of years, where there's been some huge challenges for health services to maintain energy around anything specific, and so it's been really an excellent enabler to have us as a dedicated implementation partner, and even within my team at the CEIH to be able to have this as a dedicated program team who haven't really been distracted by any of the other things that are going on around. So it's a really interesting learning for us. The increased move toward digital and virtual. Absolutely. So people becoming more familiar with technology and incorporating that into their practice is definitely an enabler. And that includes the patient population. So consumers using QR codes across the system, across the whole of the public sector, I guess, and other areas has really been a game changer. We have the data warehousing capabilities, and certainly from a leverage point of view, those national initiatives and the frameworks that are coming out to say, actually, this is the way to go, this is what we should be doing, is an enabler for us locally as well, because it has to matter. So it's very exciting times. And I think almost finally, I can't see the back end of my slide deck, but I'll keep going until it stops moving, that success will look like that data is available to all, so that equitable access, and is actually used by the clinicians and by their services, and then by the system as a whole. That's really important to us, and that's important that we get that right. We would like to see survey response rates of 80%. That's a pretty big goal, but we hope that if it's relevant and meaningful and engaging for people, and our learnings from overseas is that where there's something in it for the consumer who's answering a survey in terms of what they get from participating for themselves and from their service providers, that does increase compliance with people thinking, yeah, we will reply to that survey. It's not just a one-way transaction. They're actually part of the conversation. Policy and service change that's resulted from that data, the patients using their own patient-reported measures outside, and so really excitingly, we do anticipate with our program, patients will be able to see their own data and where it's trended over time. They'll be able to see how they're tracking themselves, and we hope to see that those consumers or patients will then be able to take that data with them, back to their GPs or back to other service providers who are working with them, and share that longitudinal score or insight that they have gained themselves from being able to have access to that data. We hope to achieve a balance between survey burden and what people get out of it. So again, balancing the effort people have to make to engage with these types of things with what they get out of it at the other end. We hope to see the workforce are satisfied, and that the experience data is used to impact staff wellbeing. And this is really important for us more broadly, recognising that we want better outcomes and experiences for everyone in the process. We know that one of the really wonderful benefits of patient-reported experience measures is that often people who work in health never know that they're doing a good job, or never know where they might be able to improve. And so we do hope that we're able to design systems so that experience data is used to impact on staff wellbeing as well, which will be a fantastic, exciting outcome for us. So just finally, if you would like to know more about the South Australian implementation of PRMs, feel free to jump onto the PRMs website, which is on the screen now. And you can subscribe to our newsletter. So that will mean that you'll get the regular updates from the team through the newsletter. Back to you. Thank you very much.
Thanks so much, Katie. That was really great. It provided a really good introduction, and also I learned quite a bit about what the Commission is doing in this space. And that last slide on success was great. It obviously a lot of time's been put into what we want to get out of this, and the 80% target also shows that you're planning on having continual feedback and tweaking to try and meet these targets, which it is really good to see as well. So thank you. So next, we have Nadia. So she's a Senior Research Fellow at the Rosemary Bryant AO Research Centre at Uni SA. She's an experienced behavioural scientist who has worked extensively with industry, government and non-government organisations on research and evaluation projects focused on supporting people recovering from illness. Her expertise includes measurements and psychometrics, evidence synthesis, co-design, and quantitative and qualitative methods. So Nadia, if you would like to take over. You're on mute, Nadia.
Thank you, Sarah. And thanks, Katie. I really enjoyed the presentation. Are you seeing my screen?
Perfect. Thank you.
Okay, wonderful. Thank you so much. So I'm going to be talking about core outcome sets and focusing on cancer survivorship, which is the area that I have experience in. And I'd like to acknowledge my colleague, Dr. Imogen Ramsey, who's pioneered a lot of the work that I'll be presenting today in her PhD. Okay. Okay, so patient-reported outcome measures, and that'll be my focus today, the outcome measures as opposed to the experience measures that, that Katie introduced. Often with patient-reported outcomes, we're trying to measure quality of life in some way, shape or form. And quality of life's a really interesting concept because we all sort of intuitively know what it is and understand that it's important, but it's not something that can be easily measured directly. So instead, we infer quality of life by making an assessment about other areas of health. So this is depicted in a very simplistic or simple way in this diagram. So I focused here on, mental health, physical health, and social health. Those areas are determined by a number of factors, and they're represented in the smaller circles around the outside. So with the patient-reported outcome measure or the survey that Katie talked about, what you see is questions asking about the sorts of issues that are represented in the smaller circles. Then what we do is we use that information to make an assessment about different aspects of health. So it might be the mental health, physical health, social health. And then based on that, we make inferences about the person's quality of life, for example. And to work out what that actually means, that there are different ways to do that. You can look at changes in scores over time. There can be comparisons to normative data. So it's outside of the scope of this presentation to talk too much about kind of the measurement of quality of life and patient-reported outcomes, but just to raise awareness that there is quite a lot of technicality in the measurement of patient-reported outcomes. And if you are working in this space, it can be really helpful to get some advice from someone who has some experience in how patient-reported outcomes are measured and interpreted, because it can be quite a tricky area where you're collecting a lot of information in a single survey. So this is very similar to one of Katie's slides. So we have different applications of PRO data in healthcare. This is quite different to the way that patient-reported outcome or quality of life measures are developed. So typically in a research context, patient-reported outcomes are developed for the purpose of research. So as a primary outcome measure in its own right, or often as a secondary outcome measure. You may be familiar with patient-reported outcomes being used as a secondary outcome in clinical trial, for example. That's quite common. When we're using PRO data in healthcare, we're using tools that have, in the most part, been developed for a very different purpose and applying them to these sort of applications that Katie explained so nicely. And that involves quite a bit of adaptation and judgment in order to kind of achieve the intended outcomes for the different levels of application. So I became interested in cancer survivorship or quality of life in the context of cancer survivorship quite some years ago. And this area really appealed to me when I started reading about cancer survivorship, and really appreciated the potential for improving patient care by using PREMs in clinical practice. And that was something that I found really quite motivating. And I was interested initially to know whether this sort of information was being used routinely internationally to improve patient care, or even more so to understand sort of what some of the big trends were in quality of life from the point of cancer diagnosis and post-treatment and beyond. And so we undertook a systematic review and found that there were 7 cancer survivorship monitoring systems internationally. So not a huge amount, but there were some established systems. And what was interesting is that there was great heterogeneity in the data that was collected by the different systems, and importantly, a lack of detail around why particular outcomes had been selected and what the purpose of collecting that information was. So that we felt that there was a need for a core outcome set to inform what outcomes to collect as a minimum in this type of research or in this type of setting to improve the comparability, quality and usefulness of the data collected. So we embarked on developing a core outcome set for cancer survivorship monitoring. So what is a core outcome set? So essentially it's a list of agreed upon outcomes that aims to provide standardized recommendations regarding what to measure and what to report on as a minimum in a particular area. Core outcome sets have been developed for many different areas of health research, and usually in consultation with key stakeholder groups such as clinicians and consumers. And the process typically involves first identifying all the outcomes known to be associated with a particular condition, and then asking experts to reach consensus on which outcomes should be considered core or critical to assess at a minimum. Katie talked about the burden of, there's a balance between how much information is collected and what people can be reasonably asked to do. And so core outcome set really is trying to address this issue by identifying, okay, so what's really, we know lots of things are very important, but what is absolutely critical at a minimum that we should measure. Adoption of core outcome sets in health research can help to ensure that studies assess outcomes that are considered relevant by consumers and by clinicians, and also limit outcome selection and reporting bias and improve the consistency and comparability of data collected. And there are established guidelines and methodological tools to support the robust development of core outcome sets. Okay, so as the potential for PROs to inform care and quality monitoring and service improvements and health policy has been realised, so too has the critical importance of how these outcomes are selected, measured and reported. Now, there are a few measurement issues associated with the inclusion of PROs in research and in healthcare settings. So often PROs are not always included in a meaningful way or with a particular objective in mind. And because many PRO measures are multidimensional, as I showed in that initial slide with all the circles, it can be sometimes hard to know if all the outcomes assessed are reported or if there's been a bit of selectivity, well, let's just focus on these and use these. And that can really create an issue where you have potential for bias. And with so many PRO measures available, I mean, there are hundreds when you start to look at them that have been developed for different purposes, across different disciplines with different scores and terminology. It can be really difficult to make sense of the data and to compare and synthesize across studies, but also across settings and similar applications. So core outcome sets are a way to help address some of these challenges. So before commencing the work that we undertook, or that Imogen Ramsey led, we did a systematic review of core outcome sets that had been developed for use in cancer that contained PROs. And there are a lot of core outcome sets in cancer, and some of them do contain PROs. But what we found is that the detail and advice around the PROs included in core outcome sets for cancer are often quite vague. So there might be a recommendation to measure quality of life or to measure symptoms without really any particular guidance about which symptoms and which measures to use. So that kind of defeats the purpose of the core outcome set, or the patient reported outcome aspect of the core outcome set, without any guidance on how to achieve that. So from this review, we realized that it was important to develop a core outcome set, and that this really sort of deserved a comprehensive consensus-driven approach involving expert stakeholders, including consumers and clinicians and policy experts. Okay, so the aim of the study that we did was to obtain consensus from experts in cancer survivorship on this core outcome set of PROs for monitoring the long-term quality of life of cancer survivors. And here, what we had in mind was that macro level application, the system level application, not so much the kind of immediate sort of shared decision-making aspect. So that was our sort of view at the outset. So there's essentially three phases to developing a core outcome set. I've alluded to the first phase, where you come up with a long list of possible outcomes, and this long list for us was developed through a review of measures and also focus groups with experts or consumers in Adelaide and Sydney. And then the second phase was a Delphi study, which was the consensus forming study, and that involved experts rating the importance of the various long list of outcomes over 2 rounds in order to whittle that down to the outcomes of critical importance. And then through a consensus meeting, that sort of short list was consolidated and agreed upon. And the final phase, which is the phase that we're undertaking now, is determining how those outcomes should be measured. So in the first part, you're not really thinking about kind of tools or measures at all. It's really about what are the domains, what are the concepts that are important to people, and then at the last part is figuring out how best to measure those. Okay, so through this process, our expert panel arrived at a consensus on 12 outcomes that are important for cancer survivorship monitoring. And I have a reference list. You can refer to the published study for more details on this. But essentially, we have depression, anxiety, pain, fatigue, cognitive problems, functioning in everyday activities and roles, fear of cancer recurrence or progression, coping with cancer, financial toxicity, overall quality of life, overall health status, overall bother from side effects. So I don't think they will come as a surprise to people that work in cancer. And the core outcome set can hopefully be used by anyone to guide research and also survivorship monitoring at that system level. And really, this is designed to hopefully improve consistency and comparability of data where that is appropriate, where that's important. There was a high level of consumer engagement and co-design through the development of this process, and we did engage widely with stakeholder groups and feel that as a result, this outcome set does represent outcomes that are meaningful, relevant and important to a lot of people. And importantly, they're also considered relevant across cancer types and at different stages of the cancer trajectory, from diagnosis through to treatment and long-term survivorship. Okay, so as I mentioned, phase 3 is underway. This has been a slow burn, as this is not a funded activity, but something we're really kind of passionate about and committed to. And we're undertaking this work as a special project with volunteers from the International Society of Quality of Life, Australia, New Zealand Special Interest Group. And yes, so we really appreciated the help and expertise of individuals on that group to review lots of measures so that we can provide recommendations about how to measure this core outcome set. And we've used a particular methodology referred to as the Cosman methodology. So it's a very rigorous and detailed process. It takes quite a long time. And finally, just wanted to highlight a piece of work that we've done in this area where we really put into this paper a number of learnings that we encountered through the process of developing the core outcome set, but not just that, really just also learning about the regulatory and legislative landscape, some of the challenges and enablers that Katie talked about. We've put together in this paper this was part of a special issue of the Quality of Life Research Journal that was focused on reducing research waste in quality of life research. And there's a lot of potential with quality of life data to ensure that we have got great opportunity to do all of the things to achieve all of the outcomes that Katie talked about. And in order to do that, there are some challenges that need to be overcome in terms of how that data is collected, used and made available for the purposes of shared decision making, quality improvement, and also system kind of policy level decisions. So we talk about some of those challenges here in the paper. So if that's something that you're interested in, feel free to have a read. And also the special issue has a number of other papers that talk about, reducing waste when quality of life data is sort of collected and used. And really, I guess my key message here is there's a lot of resources involved in setting up a patient-reported outcome system, and that data can be used for so many applications. And given that, it's a great opportunity to ensure that we use that information wisely and avoid duplicating sort of effort by collecting data de novo to answer questions that data kind of collected routinely can answer. I'd just like to acknowledge collaborators, the people at the top, Marion Eckert, Amanda Hutchinson, Julie Marker and Lonica Vanderpoel France contributed to Imogen Ramsey's PhD, and the Isaac Wall Australian New Zealand Special Interest Group members who are contributing to our phase 3 of the Core Outcome Set project are listed there too, and we really appreciate their support. Here is a reference list if you're interested in more detail on the studies that I've talked about today. And thank you very much.
Thank you, Nadia. So yeah, thank you very much for that. That was really great, and it complemented Katie's presentation really well by showing, you know, a practical implementation of patient-reported measures and the real necessity for having a core outcome set. So I did have one question on here already. It was posted anonymously. Let me just pull that up. Excuse me. So someone said, terrific project. Is this lack of core outcome sets common across other clinical areas? And this is for you, Nadia.
Oh, look, there are a lot of core outcome sets in different areas. So it's not necessarily a lack of core outcome sets, but the core outcome sets relating to patient-reported outcomes, that's where there is a bit of a gap. So often you'll have a core outcome set, let's just say, for breast cancer. And there are a number of clinical indicators that are in that core outcome set. So for a particular application, often it's for a particular application and a particular population that the core outcome set is devised. And you may have a list of clinically relevant outcomes. And often, not always, but often there is a mention of a patient-reported outcome, but it may be very ill-defined. So you should measure, for example, pain, just as an example. And often it's not that it may not be that clear. Without any clarity or advice about, well, how should we measure pain? When should we measure pain? What should we measure pain with? Unlike the clinical outcomes in a core outcome set that are often very, very clearly defined. So there's a lack of detail in the core outcome set related to patient-reported outcomes. And I think it reflects some of the complexity in the measurement of patient-reported outcomes. So we know that it's important, which is why a lot of core outcome sets include them. But how to do that gets a little bit more tricky. So some of that detail is left out, which makes it difficult for people to use the core outcome set consistently when it comes to that particular outcome.
All right, thanks, Nadia. The next question is from EJ Bad, and the question relates to the role of qualitative research in PREMs. Are there currently any patient-reported measure initiatives that systematically collect patient narratives and synthesize these with PREM data? I'm thinking about how patient stories could provide useful context for longitudinal outcomes or experience data. And I think this could be for either Nadia or Katie.
I'm happy to have a go at this one. Katie, I'm not sure if you wanted to.
Yeah, sure, you have a go and then I can add if that helps. Yep.
Yeah. Look, it's a very interesting question. And patient stories is something that's of a great interest to me as well. Not to my knowledge as an approach, as a mainstream approach to inform patient-reported outcome measures, although possibly in certain populations there may be more of a kind of a history of using narratives. So I'm thinking of research undertaken with Aboriginal and Torres Strait Islander populations. The kind of narrative methodology is something I am fairly certain has been applied. Typically, qualitative research is fundamental. It's really important as part of the first phase in good development of any patient-reported outcome measure. There's a lot of qualitative work that is done up front in order to determine what matters to to the people that this questionnaire, this eventual questionnaire is aiming to assist, that it includes everything that it should, and that it doesn't leave out anything that's important, that it's comprehensive, that it's comprehensible. So there's a lot of qualitative work that's involved to develop the initial item set. In terms of stories, if I understand correctly, you're talking about how narratives can be used. I'm not sure that has been done, but it may be something that has been done in particular areas that I'm not familiar with. It's certainly, I think, a very interesting area for exploration. Katie.
No, Nadia, a great answer. I think that really importantly for patient-reported outcome measures, you described that perfectly from my point of view, in that it's almost like the patient-reported outcome measurement questionnaires have been built to enable qualitative information to be collected the same way, so that it gets used a bit like quantitative data, if that makes sense, sort of, not perfectly, but loosely, because of the effort that goes into creating them. I think certainly in patient-reported experience measures, there is value, and there is examples where narrative is used in patient-reported experience measures. We're certainly planning to do that in the work that we are leading for South Australia, and certainly if you imagine, telling people that 92% of their patients thought they did a good job versus telling them that Bob was really pleased with the care that he received when X happened, the value of that narrative is much greater probably than a percentage. So we do think that that's a really important example. I am aware, but not expert. I know some of my team on the call who are in the audience that would be able to give more detail, but I know if you're interested, there is work happening in the Northern Territory, where consumer narratives are collected as part of their patient-reported experience measures when they're discharged from hospital. So I think that's happening very much in the PREM space there as well. And from a system point of view, the system that we have will be able to collect and display those narratives in the patient-reported experience measures space.
Thank you both. Kerry Patterson, we're running out of time, but I might have to leave it on this last question. Kerry Patterson, she has asked, can you give a specific example of a policy or service change as a result of the Cancer Core outcome dataset? So that's for you, Nadia.
So the work that we've done is really in the development phase, so that hasn't been implemented. So there is no hasn't been any opportunity for a policy change, but this is something that we reviewed in the initial systematic review that I put up. So the international monitoring systems, we looked at examples of kind of what the outcomes, what they achieved essentially from a policy perspective. And one, well, sort of testing my memory, but one comes to mind, I think it was in the Netherlands, where they have a cancer survivorship monitoring system. And one of the areas that came up was, I think it was insurance. So there were some patients were being denied insurance in particular areas. I can't remember the details, but this came up time and time again. And they were able to kind of bring this to government and address this with the insurers in order to kind of rectify the situation that occurred. So I think people were being treated unfairly if they had a cancer experience, and through the kind of collection of this information at scale, this was kind of able to be used to change policy, and then that benefited people with cancer kind of broadly across the Netherlands. There were some other examples as well that just don't come to mind as easily at this moment. But yes, there definitely are examples of this type of information leading to really significant changes.
Right. Excuse me. Thank you, Nadia.
Probably, I know we're out of time, just quickly to add to that, just locally in the breast cancer space. So one of the teams in South Australia who've been using patient-reported outcome measures, their work has led to a change in the way that breast reduction surgery for hyperplasia has been seen. So it used to be seen as cosmetic surgery. It's no longer seen as cosmetic surgery. So the patient-reported outcome measures have led to policy change in that space. It's a really nice example if you look that one up.
Great, thank you. Well, that's brought us to the end of the session today. I just want to mention next week's webinar, which is patient-reported measures in clinical quality registries and clinical trials. We'll hear from Professor Belinda Gabe and adjunct Professor Nick Sepps, both from Monash University in different areas. But I'd like to thank Katie and Nadia for your great talks today and for everyone who has listened in today. And that brings us to the end of today's session. So I'll sign off. Thank you all.